Hey, hi everybody. Welcome to the National Empowerment Center's Compassionate Approaches to Crisis webinar series. Today's webinar is called Warmlines, Crisis and Supplemental Supports, and it's going to be presented by Jess Stolman-Rainey. I'm Shira Collings, and I work at the National Empowerment Center, and I'll be moderating this webinar. I'm really excited about this series because I think there's a lot of really great peer-run alternatives to crisis responses going on and happening that are especially relevant during this time. And so I think this is going to be a really great chance to learn about what's going on and what can be done for people experiencing crisis besides hospitalization or more conventional approaches. So would you mind going to the next slide? So this webinar was developed in part under grant number SM062560 from SAMHSA, the U.S. Department of Health and Human Services. And the views, opinions, and content expressed in this presentation do not necessarily reflect the views, opinions, or policies of the Center for Mental Health Services, the Substance Abuse and Mental Health Services Administration, or the U.S. Department of Health and Human Services. Could I have this webinar will be recorded, and the PowerPoint presentation and audio recording of the teleconference will be posted to our website, which you can see the link there. So at the end of the webinar, there's going to be a Q&A session. So you can ask questions through the question function or through the chat feature. You can also make comments. This is a pretty large webinar. I think we have over 500 registered. I think right now there's 180 in attendance, and that's increasing. So we probably won't have time to get to all of the questions, but we'll take them in the order that they're received, and then Jess's contact info will be posted if you have questions that aren't addressed. So this first webinar is on Warmlines, and I think that's very relevant during this time. People are in need of support they can't always access in-person support right now during the quarantine, and so Warmlines are especially relevant, and I'm really excited for the opportunity to hear more about those, but I wanted to introduce Jess first. So Jess is a researcher, trainer, and activist serving as the Director of Program Development at Rocky Mountain Crisis Partners. She has focused her career on creating pathways to intersectional, justice-based emotional support for marginalized communities. Jess centers her lived expertise as an ex-patient and suicide attempt survivor in her work. Her work has been featured in Mad in America, Radical Abolitionist, No Restraints with Rudy Caceres, Mental Illness, Research, Education, and Clinical Centers, Postvention in Action, the International Handbook of Suicide Bereavement Crisis, and the Suicide Prevention Resource Center. She collaborates on a podcast called Suicide and Stuff with Desiree Stage from Live Through This. She holds the lived experience seat on Colorado State Prevention Commission and was the winner of the 2019 American Association of Suicidology Transforming Lived Experience Award, the 2019 Cookie Gant and Bill Compton LGBTQIA Leadership Award for Excellence in Promoting Diversity and Inclusion, and chairs the Paul G. Quinnett Lived Experience Writing Competition. She lives with her partner, John, and a 16-year-old Marty, and has a taxidermied two-headed duckling, Phil and Lil, for an office mate. So thank you so much, Jess. I'll turn it over to you.
We had that moment about my dog because my dog actually passed away just recently. So I had submitted that before that happened. So that was a little bit sad. I'm really, really excited to talk with everyone about Warmlines. I think that as someone who has worked in a lot of interesting spaces where clinical services and lived experience are either co-located or working closely with each other. I think that the value that peer-run services bring to state and local places is just really irreplaceable. And as more spaces start to engage in peer support, we start to see more outcomes that are a really great way for us to be able to make a case for why these things should be involved in our mental health services, either as independently run organizations or integrated into other services. So let's start with what a Warmline is. Warmlines started to offer peer support telephonically. They often involve a follow-up or a callback service. So you might call into that line and then leave a voicemail and get a call back, or potentially have an initial call and then get some follow-up from a person. Sometimes they are peer run and sometimes they're integrated into clinical settings. They generally don't have service level agreements regarding live answer or call abandonment. So basically what that means is most contact centers that are doing crisis work have a contract with someone to provide it. And oftentimes there's a service level agreement or an SLA that says that you have to answer this percentage of calls, of the calls that come in. Other calls that are abandoned mean that someone either hangs up before they get connection, or we aren't able to get to those calls. So they have agreements about that. And generally, Warmlines do not have an SLA. They're often connected to face-to-face services. So you might have a Warmline that's embedded in other peer support services. There may be a Warmline that's embedded with a hotline service, things like that. They're often sort of co-located with other services. I wanted to just take a minute and sort of differentiate hotlines and Warmlines, and then kind of talk about like what peer support lines can be in the context of those two things. So hotlines are usually connected with crisis and or suicide. So they're often like a domestic violence line or a suicide hotline or another sort of crisis oriented line. They typically include screening and assessment. So especially if they have accreditation, they're going to be asking every caller about suicide. They're going to be using some kind of screening tool and probably an assessment tool to make a determination about a level of care. So those are going to be much more clinical in nature, even if they're not run by clinicians, which many of them aren't. They also typically include active rescue policies, and active rescue is a really, really nice way of saying coercive policies. So what active rescue means is that they will, under the guidelines of that state, because every state is slightly different, there'll be an imminent risk policy and a mandatory reporting policy. Those two policies will sort of determine when they are going to force an intervention without the person's consent. And typically that means contacting 911 to do a welfare or a wellness check. I'll talk a little bit more about that later on too, but to me, this is one of the biggest differences between what's considered a traditional hotline and a Warmline, is whether you're going to be exposed to active rescue. And they may not work with people who are in that pre or post crisis state. So they may have some really strict sort of determinations about who is allowed to utilize that line and what their experience has to be for them to be using it. Warmlines may use a voicemail or callback service. They typically do not provide clinical screenings or assessments. And I would say they typically don't, and they shouldn't be providing clinical screening and assessment. They may refer people in crisis to other services. So sometimes it is part of the contract that a Warmline has that if someone is expressing like certain kinds of thoughts or is engaging in certain kinds of behavior, specifically around suicide or harming other people or harming themselves, that they're referring to other services. That's something I really want to push on today, is that I really firmly believe, and we operate my Warmline in under the belief that peer support is equally valuable and can take the place of clinical services. And if that's the case, it doesn't make sense to be referring someone in that level of crisis to someone else. And they typically also work with people who are pre and post crisis. There's not those strict definitions of who gets to utilize the line. Some of the things that are in common is that oftentimes these services will say things like crisis is self-defined. They'll talk about the agency of the caller. What that means in implementation is going to look really, really different between these services. Sometimes there's also a connection between hotlines and Warmlines. So there are some services that might be set up more like my organization, where there's a hotline side and a Warmline side, and any follow-up that happens comes from the Warmline. In my organization, the way we differentiate these two services is by caller choice. So when you call into our contact center on our crisis line, you are going to be prompted first thing. First you'll be asked about Spanish or English, and then you get to make a choice between whether you want to talk to a crisis clinical person or if you want to talk to a peer specialist. So we like to present that choice up front. Some other places offer that opportunity in different ways. And then some places are exclusively a hotline or exclusively a warm line. In a lot of crisis kinds of spaces, there's differentiation between hot and warm calls. So hot calls, which would be calls that would go to a hotline, or in some cases, they might think belong with a clinical setting, would be people who are experiencing suicidal or homicidal thoughts, anything involving rape, incest, or assault, domestic violence, child and elder abuse, and grave disability. Warm calls then would be experiences with existential or spiritual crisis, navigating services or symptoms, pre or post crisis concerns, leaving hospitalization or other treatment, and then needing community or support. At my center, we handle both of these kinds of calls on both of our lines, and really are giving people the choice between peer services versus crisis, clinical crisis services, and not differentiating like the type of call in the same way. So this looks a little bit different where I work because of our approach or thinking about what peer support is and can do. So let's focus a little bit on peer-run Warmlines. So if this is a Warmline that is exclusively peer-run, that means it's autonomously run by peer or recovery support service organizations. It typically does not have clinical oversight or protocols, although depending on your state laws or the way things are funded in your state, there might be requirements that your peer-run services have clinical oversight. I think that's pretty problematic, and I think there are some really great ways you can work around some of that. When we get to the resources section later, I will talk about some resources that you can use to kind of wiggle around some of those requirements in your state, because part of what happens is peer support gets diluted by having clinical oversight, and you start to see clinical practices seeping into the peer work. They might refer to independent crisis services. So there are some Warmlines where if you contact someone and you're experiencing some pretty intense suicidal thoughts, they might send you over to a crisis line instead. I think that that's unnecessary. I think that you can get training for your peer team to appropriately work with people experiencing suicidal thoughts, and I'll tell you about some of those trainings that I think are really excellent. They often operate outside of the formal mental health service system, but may have a relationship with it. I think the more independent they are, the more likely it is to be like true peer-run service as opposed to something that has clinical practices seeping in. They support peer values and are going to maintain peer values over any kind of clinical intervention. And oftentimes these organizations struggle a lot with funding because typically what happens if crisis services are even funded by a state, or hotline or Warmline services are funded at all, these services are, the clinical services are given far more funding, and then the peer services are kind of given this like side chunk, and it often is set up that way because Medicaid has made some distinctions that you have to have peer services offered, and so they really designate a certain amount of funding for those services, but it's not ever comparable to what you're seeing for crisis services. I think there's some interesting things about that because oftentimes warm lines are serving a sort of smaller population of people, and having worked in a place where um, we have both a hotline and a warm line and are funded for the two of them together. We get to see the sort of the amount of people that are going to choose peer services when they're prompted and given the choice. And one of the things that we've seen is that our peer support numbers, so the growth of our peer services has outpaced our clinical services by kind of a landslide. And both of them are increasing rapidly since we've opened our line. But I think one of the things that's really important there is that people think there's less of a demand for peer services, and it's actually that there just are fewer peer services available, so we can't even track what that demand looks like. So because we have had access to the same technology and funding and things like that for our peer services, we've started to see that look really different. So our peer line takes between 5,000 and 6,000 calls a month for the state of Colorado. And all of our other clinical lines, and we run a ton of clinical lines, combined are taking somewhere between 15 and 16,000. So that gives you kind of an idea that peer services are in pretty high demand in comparison with what people think they are. The other thing that's interesting about that is because of some of the staffing that we've experienced, we actually don't advertise our peer support line. The crisis system only advertises the crisis side of the line. So all of that growth in our peer support services has come from word of mouth, not from the advertisement of the peer services. So talking about a clinically embedded warm line, some of the things that you might see in a clinically embedded warm line is that they are delivered alongside, in conjunction with, or secondary to other crisis services. They may include screening or other clinical protocols. They probably should not, because there already is a crisis option for people to choose, or a clinical option for people to choose. So it doesn't really make sense to me that you would include the same interventions on both spaces, but you see that happen a lot because I think there's often mission creep happening in those spaces. Or you have clinical folks overseeing that line, and so they start sort of implementing clinical structure into it because that's what they know. They're often also connected to a series of other clinical interventions. So when there's a referral that's taking place, the referral is likely to use all of these clinical options that might exist in that space, because that's the database of resources that is shared between the two. It's also often considered a powerful addition to a clinical intervention. So in those spaces, you might see some more respect for peer support than in other clinical spaces. But I also think there's more risk of compromising peer support values. So sometimes that respect that clinical services might have for peer services is actually coming from peer services becoming more like clinical services. They often have less struggle with funding because of the equipment and space sharing with clinical interventions. Sorry, that bottom got cut off there. So there's some benefits to being clinically embedded, but there's also some really serious risk in engaging that way, of becoming more like a clinical service. In my current role, part of the reason that I came into Rocky Mountain Crisis Partners, where I work, was to help them with developing their peer program to be a more independent program from crisis services and to really look more like peer support as opposed to something that's just a different version of a clinical intervention. So prior to my work there, we our peer support line was doing things like screening and was sending callers who peer specialists felt like were experiencing some really intense suicidal thoughts or something like that, who they felt were like out of their scope. I'm going to put that in quotes because I don't think that things are out of peer specialist scopes. Um, they were sending those calls over to the crisis line. Um, Now, there's still interaction between our peer and our crisis line. Sometimes people on the crisis side will inform their caller about peer services and send them over to us to get an introduction. Sometimes people, push the button to go to the peer line, and then when they understand what the peer services are, they prefer to talk to a clinical line, and so they get sent over. But since I came and really worked on developing this peer program as a more independent program, and pulled out all of the clinical stuff that was being taught in the peer training, um, the peers are really handling similar types of calls to our crisis line, and then we just do that in different ways. And we've really seen a growth in our the kinds of callers that are utilizing that service because what we're finding is that there are all these people who have been potentially harmed by or are afraid of some of the interventions that come with clinical services. And so they're choosing to work with peers. So our callers now are really starting to understand the difference between those two services because we've made them really distinct. Whereas previously, there was just a lot of overlap and a lot of gray area between those services. Funding for anything crisis and telephonic is really, really difficult. So there are kind of four primary sources of funding. There's Medicaid billing, and in some states you can bill for Medicaid services for peer support services. And sometimes of those services you can bill telephonically and sometimes you can't. One of the challenges with Medicaid funding is that it often comes with a caveat that you have to have clinical oversight. So that has the potential for mission drift in your peer organization. The second source of funding would be community support. This is also often challenging because people who have been psychiatrized and people who might be using peer support services or supportive of or engaging with loving peer services are often not people who are able to fund them through private donations and things like that. So I think there's some challenges to community support. Not that the community doesn't support the organization, but the community may not be able to fund it in a realistic way because of the discrimination that they experience. But there are peer support organizations that are funded through community support, and there are definitely ways you can do that through funding strategies around individual and corporate donations. The third is foundation support. So this can be traditional foundations. We have some pretty diversified funding around this. We get money from folks who are really invested in substance use recovery. We have a lot of people who are organizations who are invested in health equity. So I think that's a really good kind of space to start looking for funding in the foundation space. If you're trying to create this kind of warm line, is to look for organizations that are talking about things like equity or justice, because they are more likely to recognize the value of lived experience over clinical expertise. And then the final one is government support, and I feel like this is actually the most common in telephonic services. So oftentimes there are systems for responding to crisis that the government is supporting in a state or a local level. And that's where our largest contract comes from. Is the state of Colorado has a crisis system that was developed as a emergency department diversion program. So our system is all designed to keep people out of EDs and hospitalizations. So peer support is sort of embedded deeply in that. That's where our contract comes from. Government support is another one of those spaces where you might be looking at some demands about clinical oversight that maybe are not lining up with the way that you might want to run peer services in your local level. Again, there are some really interesting ways that you can work within those parameters and still do some really, really good work with people. And we can talk more about that, or I'm happy to follow up with people if you have more sort of unique individualized questions about it. All right, let's talk about technology, data, and documentation. Within the crisis telephonic service world, there are just a lot of considerations around this. There are a number of ways that you can run these lines. I know some places are picking up physical phones. The phones ring, in a center, and there's a few stations set up, or maybe even just one phone, and people are picking up the line and talking to people. And I would say that's the sort of lowest hanging fruit if you're looking for just being able to set something up and have it working. As your work starts to grow, if you're serving a larger number of people, you start to see some really different types of phone systems, and start seeing some need for different kinds of recording and documentation and things like that. So documentation is this space where I think some really interesting and complicated things happen around peer services. So I think in peer support tradition, documentation is generally not something that we think about doing. And there are lots of really good reasons for not documenting work. There are some challenges that come with that. When people can see previous documentation, they can see, sorry about that, I had a cough and didn't want to cough in all of your ears. They can see the previous documentation and see sort of what the other person thought were the problems that were going on, or their attitudes about that person, and it can really bias people. Some of the pros that can come from documentation would be that you can start to see some of the things that worked well with someone and things like that. So I think there's lots of questions around documentation. Documentation at my organization is a requirement. It's under our contract. It goes in an electronic health record. And so if you are going to engage in documentation, it's really important that you're honest about that, and that you set up your documentation as a Warmline around the way that you are engaging in services. So our notes for our calls that are connected with peer support services are all about, here are the things I did to support this person, as opposed to here's what this person had going on and what I think was like wrong, or how I might diagnose them, or things like that. So aligning your documentation with the service that you provide is really, really important if you are going to document. There's other kinds of documentation besides documenting everything that happens in a call too. So you might have requirements for documenting the number of calls you get, data reporting about that, things like that. Those things can get more complicated if you're not writing anything down about calls. I think Trans Lifeline has one of the most interesting I think great documentation systems for peer support, because they basically do tagging around content, and then they can sort calls so they can talk about, like, we had this percentage of our calls addressing these issues without actually documenting anything about what happens in the call. So I think that's really powerful. Um, some of the requirements around documentation in other settings, especially when they're clinical settings that also provide a warm line, sometimes the purpose of some of that documentation is so that people can engage active rescue. So oftentimes the questions that are being asked are going to be about like where you currently are. So you can kind of tell based on some of the questions that are being asked when you first call what the purpose of documentation is. If you're ever contacting a warm line or a crisis line and they're asking you those kinds of questions, you should always feel like it's okay for you to ask why they're asking and get a really good answer from them. And if they're not answering you, it might be worth trying a different service. All right. So there are kind of two types of phone systems. Traditional phone systems are sort of the ones I talked about, where a call is going to ring through, people are going to pick up a phone and talk to someone. Um, those are typically the kinds of phone systems that you see at smaller lines that are handling a lower volume and have lower staffing, especially in sort of volunteer run spaces. And by the way, I want to just add one thing about volunteer run. So I think that people should always be paid for crisis work, and oftentimes they are not. And if you're in a space where your peer line is volunteer run, but a clinical line that's in your space is not, um, that's a really big problem. And there are some really great things you can do to advocate for getting pay for those folks, because that's just discrimination at that point. So traditional phone systems are typically going to be connected to lower volume, lower funded, and volunteer run programs. Web-based systems are going to look more like call center environments. So typically you're going to have a headset. So this is my headset for my call center. You would have an internet-based phone system. You can see a queue, which shows you like all of the calls that are coming in, and how many are waiting and how long they've been waiting for. So it's a more advanced system, and there are tons of options for those systems. There are some great things about that, and then there's some other things about those systems that are really difficult. As you're on a call with someone, if you can also see that there's 14 other calls waiting, sometimes that changes the way you're interacting with that individual, and that can kind of work against peer support and peer support values. Recording calls is a pretty common requirement, especially in crisis services where people might be expressing suicidal or homicidal thoughts. Um, there are a lot of perspectives about recording calls. I want to sort of talk about some of the drawbacks and some of the benefits of recording calls. So I work at a contact center that requires our calls to be recorded. We record every single call. The call recordings are, we follow sort of HIPAA regulations about how long you keep those and all that stuff. The drawbacks of recording calls is that people know there's a record of the things they call in about. There's a chance that people could try and get hold of those recordings, things like that. We have never, in our organization, we have never gotten into a place where we have had to turn a call recording over to like the police or anything like that. That's not something that we have experienced. We have gone to court about those kinds of things, or gotten subpoenaed, and we really protect our callers and their identity and the content of their calls. I don't know that every call center would do that in the same way that we do, but that's something that's very important to us. But the internal purpose of recording a call is actually for supervision purposes and for helping people to grow in their work. There's something that's extremely powerful about being able to, after the fact, listen to the way that you engaged with someone to help you learn and grow in your service providing work. And there's not really another way to do that. Most people really hate listening to their voice being recorded, but it's a primary supervision tool that we use in our call center. So there's some benefit there. We also know that there are people who don't call us because our calls are recorded, or who don't want to engage with us because calls are recorded. And I think that's really unfortunate, and it's a huge drawback of our system that there's not an option for us to just turn off call recording or something like that. Um, but recording calls is often a part of people's contract. You can also use technology to provide online emotional support. I know this gets a little bit outside of the scope of most Warmline's work, but you can have text and chat services as well. Text and chat services volume nationally way outpaces our volume on crisis lines, and is often people's preferred way of getting support. I think there are a number of kinds of disabilities that make text and chat services more appealing. I think there are um, sort of personal concerns that might make text or chat more appealing to people. And those services are all going to be sort of connected to something like a web-based phone, except it's going to be an SMS provider. It's a really interesting way of engaging in support. So the largest provider of text services is Crisis Text Line. They tend to be a pretty big proponent of active rescue. So I think there's some big differences there, and they're not a peer run line; they're volunteer run. Although many of the people who work there have lived experience, and I think it's atypical for peer services to be delivered through text and chat, but it is a space that I think has a lot of really great room for us to grow peer services into this new space that would help us serve new populations in different ways. So that's also a consideration. Technology is also typically connected with dispatching services. So if you happen to work in a space where the the system that you're connected to might send a mobile crisis provider or mobile peer support or things like that, you can get technology that sort of auto dispatches another organization, and where you can track that person, like they might have a cell phone that has GPS on, so you can see when they're going to arrive, contact that person, let them know, hey, the peer that's coming to meet you is 5 or 10 minutes away. Can you make sure that you go outside to meet them, or things like that? So there's a lot of benefits sometimes to having dispatching services available, and there's lots of room for technology to engage in that. So just a few things about the evidence base for peer support. There's data that shows that peer services cut hospitalizations in half, increase engagement in self-care and wellness, and decrease negative experiences with extreme states. The Georgia Department of Behavioral Health and Developmental Disabilities found that using peer services in treatment saved an average of over $5,000 per person for the state. And Crisis Now found that Warmline and Hotline presence decreased ED utilization for psychiatric emergencies. Um, the reason I picked these 3 pieces of evidence is because these are really, really strong cases for your local systems funding peer services in this way. And Warmlines tend to be, while they have some big investment up front, they have the capacity to serve the highest number of people. So if you're looking at developing a Warmline or making some of your services telephonic, these are really great. So in the when you download the PDF, you'll be able to hyperlink to all of this data. These are really great tools to use to help you get your Warmline supported. Training staff is a sort of hot topic in this area, I think. So my staff training for new hires is 3 weeks of full-time training. That includes almost a full week of how to use our technology because we're a tech-based phone system, a web-based phone system, and we have an electronic health record, and so there's some complication there. We also spend a lot of time doing role play and helping people sort of understand our approach to peer support. That is not possible if you're doing a volunteer staff. Most people cannot sign up for 120 hours of training in order to be able to do the work when they're volunteers. So the differences between volunteer and paid staff are often around training or the availability of training. So your training of your staff is going to be a lot more general, and there's going to be a much higher learning curve if you're using volunteers. I don't think there's any problem with that. It's just kind of a different way of operating. I have really, really strong feelings about the way that peers are often paid differentially from clinical folks. So I think that if using volunteers is fine, but it's not okay to exploit people with lived experience when you're paying others. So that's a really important consideration, I think. And then there's choices to make about certification. So peer certification can be a pathway to being able to access funding, and sometimes that is really important and necessary for your work to even be able to exist. And then sometimes certification can be sort of a breeding ground for co-optation, and sometimes both of those things are true. So at my organization, we do not require certification for our peer specialists. It's really important to us that peers not have to take that certification test. Our local certification test has some things in it that have definitely been influenced by clinical perspectives that when people are trained at our organization, they might struggle with some parts of that test. And there are things about the testing environment that's created that are really, really inaccessible and that we have some concerns about. So we've made the choice that certification is an option for our staff, and that we pay for it if they want to do it, but that we don't require it of our staff members. We also do not receive Medicaid funding, so there's a possibility that if we were to start being able to bill Medicaid, that we might have to have our peer specialists certify in order to be paid by that. And that's really complicated because it also opens the door for us to pay better wages for our staff and things like that. So it's a really critical conversation in our organization right now as we're looking at what Medicaid funding might mean. All of those things are going to influence your training. So if you are trying to certify peers, your training has to line up with your state's certification or some other certification protocol. So we have aligned our training so that it you're qualified if you've taken our training to take the state certification test, but we also include a whole lot more and sort of approach things a little bit differently than our state certification would. So there's a lot of decisions to make about training. I have in our resources section put a couple of different trainings that I think are really, really great that you could utilize so that you don't have to develop your own training for your peers. If you're going to use an outside training program, you'll still want to develop an internal training program that's about your own policies and practices to enhance that, because people aren't going to learn about that stuff through an external training program. There is a billing code for Medicaid, and it's often tied to certification for Warmline services. So I just wanted to briefly talk about COVID-19 and how that has made how that has influenced peer services or telephonic peer services. So there's an increasing demand for no contact services, so telephonic and online emotional support. And actually, there are a lot of face-to-face services that have gotten permission to move to telephonic and online platforms. So many folks who were actually doing face-to-face peer services are now doing that in different ways. There are some pretty significant concerns about privacy in online and work from home environments. There have been I'll talk about these in a second, but there have been some changes to the way legislation is working during this crisis time that allow people to work in sort of different environments. But I think there's a really strong consideration still that your organization should take if you're going to be engaging in these services differently. So to me, maintaining a HIPAA compliant workspace is really, really important. You don't want your partner or your neighbor to be hearing the conversations you're having with people if you're delivering these services in your home to other from on the phone or online. The Office of Civil Rights at the U.S. Department of Health and Human Services announced that it's waiving penalties for HIPAA violations right now against healthcare providers that are serving through everyday communication technologies just during this health emergency. So what that means is your providers of peer services or clinical services or whatever it might be can get on Zoom with you and do that session or have those calls, and they don't have to align with the HIPAA standards. So that's really important to know if you're a service user, that when you're calling or when you're engaging, these things have changed. SAMHSA also now allows for the disclosure of health needs to another provider without written consent under the medical emergency exception. I have a lot of concern about this because what this means is that instead of your information being protected during this time, your information has become much more portable. So what that means is that SAMHSA, under the SAMHSA rule, you can now, if I was providing a peer service to someone and they mentioned that their therapist's name, theoretically, I could call their therapist and tell them what we talked about if there was an emergency. I think there's some problems in that. I think those are important things to know because there's a little bit of wiggle room, I think, now to start up some of these kinds of services and give you time to sort of develop policies and practices and a workspace that protects people's privacy and information really effectively. But also there's a lot of room for some really dangerous things to happen with people's information right now. So here are some resources that I think are helpful. Warmline.org has a list of all of the Warmlines. The National Association of Crisis Center Organization Directors is a really great space for information sharing. There are people as a part of that organization who run Peerrun lines all the way through volunteer crisis services, the runaway hotline. So it's all directors of those organizations who share information. There are, they call them peer support webinars, but they're peers as in other crisis organization directors. But I think that's a great space to really find consulting and things like that. The National Association of Mental Health Provider Directors has a training on creating and developing peer warm lines. Peers for Progress has a starting a program section where you can download all kinds of information. Here's the space where I was talking about some of that wiggle room you can have about clinical oversight. So Vicki Reynolds is someone whose work I really, really love. She works in Canada in responding to the opioid crisis, or she calls them the opioid political killings. And she is a clinician, and she works with a number of other clinicians. But their values are all in justice-based support. So if you're looking for someone to do consultation or someone to provide clinical oversight who is going to have alignment with peer maybe some of the peer values that you might have, who's going to recognize the value of peer work, starting with her organization and some of her connections could be a great space to do that. So some of those ways to wiggle around those requirements are to have contacts with people who do clinical work who share the same beliefs or share similar beliefs as you. So that's a great place to start. There are also people who work in the space of critical suicidology, and those folks would be some folks that I think would be good people to be involved in that clinical space if you have to engage in that way. On the suicidology website, the American Association of Suicidology, they have accreditation for crisis centers. I just want to be really upfront that their accreditation requirement will include something about active rescue. So accrediting a crisis center is often a way to get more funding for it. If you go about doing that accreditation, you will have to have an active rescue policy for your center. So I think that's important to know. If the next one is Contact USA accreditation, their accreditation looks a little bit different because it's not focused on suicide. So that's a place where you can get a center accredited, and then you have more funding opportunities. And then I always like to recommend Western Mass RLC's Alternatives to Suicide training if you're going to train peers on working with people who are experiencing suicide crisis or suicidal thoughts. I think their work is really incredible and some of the best peer work that's happening in that space. And then there's intentionalpeersupport.org is a great space to find some training for your peers if you're looking for an external training. Okay, so does anyone have, I feel like I've seen a few questions pop up, so I'll let someone send those my way and we can start working through those.
Okay, thank you so much for your presentation. I really appreciate it. I thought it was just excellent and very informative about Warmlines. So we do have some questions. So one question that came in here is Jess uses phrases such as mission creep, clinical stuff, peer support gets diluted, and clinical practices seeping in. I'd like more information about what she is referring to with these phrases. I've worked with 3 different Warmlines in the state of Connecticut, and I'm very interested in seeing how we measure up to a really good Warmline service like hers. Could the speaker expand a little on the difference between peer support values and clinical?
Yeah, I think that's a great question. Thank you. So to me, clinical services, especially in the crisis or telephonic space, have a really specific focus. So there are sort of 2 things that are central to clinical crisis services. One is going to be using a crisis management process. So that's a process that um, callers who call in are the whoever's the call taker is going to be working through sort of a framework of the arc of what the call is supposed to include. So that's going to include things like build rapport, you know, do some screening, start doing an assessment to determine the level of care that that person might need, and often to determine if you need to engage active rescue based on your policies about that, and then creating a plan and then ending the call. So that's kind of the what you might see in a crisis management process in most places. You also might see some things like some organizations will have a type of call, like they'll classify calls and then give a certain amount of time that you're allowed to spend on those calls that's sort of structured. That's to support volume. So those are all things that are sort of clinical practices that you might see. And the core central thing to me is that they're doing screening and assessment. The thing about screening and assessment is that they're extremely unreliable practices. The best screening tool for suicide that's in a clinical practice that exists is called the Columbia scale, as far as evidence base. The Columbia scale, when it's been tested, is about 50% effective at predicting suicidal behavior. So what that means is, like, you might as well be flipping a coin, but we have clinicians making those determinations based on um, that screening and assessment tool. So the way that they are making decisions about what a person is going to engage in is really about sort of clinical structures and not about the individual that's calling. So I think that's sort of how I think about crisis interventions. And I oversee our crisis line, and I oversee the warm line. So um, some of the things that happen because of that are that, like, there's a lot less, I think there becomes less voice and choice for the person who's calling in, or you have to work sort of against those practices to ensure that the person is having voice and choice in that process in ways that you don't when you're engaging in peer support. So alternatively, a peer support call is going to really focus on creating meaning, like co-creating meaning together, and connecting with each other about shared experiences, trying to problem solve with each other, sharing resources that might be available. And it's not going to have that kind of structure. It's going to have sort of a focus on some central tasks for peer support. And it's probably going to have focus on a different set of values. You can look at, so SAMHSA has a set of peer values, and I think I would agree with many of the peer values that SAMHSA has determined are the peer values. You can find those online. But often certain peer support practices, if you're like coming from a certain school of thought of peer support, you're probably going to have a set of values that come along with that. Clinical values are going to look different from those. So if you're working in a space where you've created a set of values that's the same for both peers and clinicians, that's where you can start seeing some drifting happening, and seeing those services start to look more and more like each other. I feel like I think I answered all of that. Did I answer all of it? Okay.
I think so. Yeah, I think that was a great answer. Thank
Great.
you.
Yeah.
Would you mind, before we go to the next question, would you mind advancing to the next slide?
Oh, yeah.
Okay, yeah, just to give everybody this information.
Yeah.
We had a comment from Howard Trackman. He wants people to know that they're working on updating the website warmline.org,
Oh,
um,
great.
but calling all lines to verify their information. And they're having a low volume Yahoo group listservs on Warmlines. There's one on Warmlines and one on Peer Respite. So you can email hdt@mbrlc.org to be added. And you can also, that way you can also verify the information for your Warmline. And that he posted that message in the chat. I believe you can see it. So please feel free to do that if you run a Warmline or Respite. So our next question is there a Warmline for teens? The person who asked this consults in a special ed consultation, and sometimes teens need a place to vent.
I know that there at least have been. I don't think there's a national one, but I know that there have been before. That actually might be a question for Howard that you might be able to answer better than me. But I know that there have been. Those are really difficult to fund. Services for young people that are run by young people are extremely rare, and oftentimes have some of the same concerns, I think, that we experience with Warmlines, about like clinical services sort of seeping in and taking over those Warmlines. The same issue happens with adults, sort of structuring how young people provide care for each other, which sort of defeats the purpose and makes it not peer support anymore if adults are structuring the way that it happens.
Absolutely. Yeah, it sounds like that's a space where there does need to be more research and funding.
Definitely.
Our next question is from someone who says they would love to hear more about ways to wiggle around clinical oversight.
Yeah, let's talk about that. That's great. So I always love when you can just like skirt around oppressive policies. So, I think some great ways to do that can be that you if you are working in a peer support environment, considering having someone on your team go and get a master's of social work and getting a clinical licensure, and then being the person who is providing services. That's something that I've seen many spaces do. So then that clinical oversight comes from someone with lived experience who has their background in peer support. I think MSW programs tend to be, that's Master of Social Work programs tend to be pathways to doing that look a little bit more aligned with peer approaches. So I think that's a great way to do it. I talked a little bit about Vicki Reynolds and finding clinical folks who are really invested in providing support in justice-based ways. So that's another example. One of the things that we've done sort of organizationally at my center is that I report directly to a clinician, and she doesn't do oversight. So technically I have clinical oversight. I report to a clinician, but she has not been sort of involved in the creation of our policies, practices, training for the Warmline. She treats our work as independent, and that we are the experts in that. So she feels that she is the clinical expert and she provides sort of clinical oversight for our clinical line. And my responsibility is around the Warmline there. So I provide the same oversight that she theoretically would provide me. So that's another space of finding, finding someone who has the right values and engaging with that, but also structuring your organization intentionally in a way where you can and can show that those things exist sort of on paper, and then engage in that process really differently. That's been one of the great benefits, I think, in our work, is that because we have this clinical line and all of the policies and practices that need to be developed for that clinical line, we can kind of keep our warm lines separate from that, but still show that those things exist. So that's a space where there's a lot of kind of wiggle room and gray area there. You can also have, so if you have to have policies or practices that you don't think are aligned with peer support, I think disclosures about those, both on your website and as people call, are really important. So giving people information like making sure they know if calls are recorded. So that's part of before anyone even gets through to a peer specialist on our line, they're going to be notified that calls are being recorded, because we think that works against the process in some ways. If you are going to have an active rescue policy, putting that policy exactly like word for word what your policy or procedure is on your website, or having it available to people who are engaging with your service, is really helpful, because then they can know how to talk about things. If someone starts bringing up something that is connected with something that you feel like you might have to mandatorily report, even though you don't think that's something you should have to do as a peer, for example, then you can have a policy and a training that supports the person in disclosing that, and giving the person who's making the call the options about how they disclose. The other thing that I think is really important here is that oftentimes we as in like the public, will interpret imminent risk policies to mean something different than what they actually mean. So imminent risk means like if nothing changes in the next 24 hours, like this person will die or will hurt someone else, and they're not willing to safety plan, they're not willing to try other things. This is just what's going to happen. So creating a threshold for engaging active rescue that's really, really high in your organization helps with that, and that's a standard that we have. So we treat active rescues, even on our clinical, on our crisis side, as a pretty critical incident that happens. It's something that we're not going to send unless there's sort of a medical emergency. So we're really only doing those things if there's like a suicide in progress and the person is going to die from that suicide in progress. So creating some standards around that that really are carefully reflecting what the law actually says, instead of basing your policies and practices on providers' fear. There's some really great resources about that. Susan Steffen has a book called Rational Suicide, Irrational Laws. I highly recommend that when you're thinking about your organizational policies and practices. And then the other side of that is training your staff not to operate from this fear space, and training your staff to consider the risks that something like an active rescue brings to the situation. So like when our even our on our clinical side, when that staff is doing an assessment, like a risk assessment, they're also considering the risk that's brought in by other interventions. And we treat restrictive interventions as things that could potentially be risky for a person.
Thank you. I think that was
Yeah.
a really great answer. And I have a peer background and I'm currently getting a master's in clinical mental health counseling. So,
Oh, she
and
could be your clinician.
okay, so I think there are probably a lot of people on this call kind of navigating both of those worlds, the clinical world,
Yeah.
the peer world, and it's so important to kind of have ideas for how to do that and how to make those values align.
Yeah.
So our next question is about text and chat services. This person asks, are there any safety or ethical concerns for texting with clients when they aren't feeling well and texting about it? For example, if a client is texting about thoughts to harm themselves and the peer service does not respond to the text right away, how is that handled?
Yeah. So our peer team does not do text and chat, but I oversee our text and chat on the clinical side. Um, Most of those services, if you're getting them set up, are going to have an auto response when someone texts in. So people text and then there's an opt-in kind of policy. So you're going to list some policies and practices. So one of the things that you would want to include is something like if your program is not going to be um, like a hot like a hotline text line, then having a disclosure about that like um, this is a service that's provided sort of under the context of a warm line. Here's what that means, and someone will get back to you within this amount of time. Um, we also have some things set up for when we have really high volume on our text line. One of the things that happens a lot with OES, online emotional support, is someone will go and do a presentation in like a high school classroom, for example, or a high school auditorium, and they give out the text line, and then we'll get 150 texts all at once because people are trying it in that
Wow.
setting. So you can create some auto responses too. So first disclosing that it's not crisis oriented, and then if they are in crisis, here's who you can contact. And so ours directs people to our line so they can still choose between peer and crisis services that way. And then we also have it set up so that after a certain amount of time, they're going to get a check-in that says like, okay, so we're still experiencing high volume. Here's where you can connect through the phone lines. Otherwise, you can stay on and we'll wait for you, or you can wait for us and we'll get to your text. So sort of building in some of those auto responses that are going to take care of all the disclosures that you need to make, I think is a really great way of engaging in that.
Great, thank you.
Yeah.
Um, The next question is whether there's a billing code for peer specialists through Medicaid.
There is. I don't know the number because we don't use it, but I do know of other peer services that do bill Medicaid. Um, it's often a decision that the state makes about whether or not they're allotting dollars for that or not. So sometimes that has to go through legislation to be supported. There's some legislation in Colorado right now that we worked really hard on that originally was going to allow peer services to bill for Medicaid, including at Warmlines without clinical oversight. And they added clinical oversight back into the legislation, which is really unfortunate from my perspective. But billing for Medicaid could really be transformative for the funding for our peer line at my organization. So there's lots of considerations to make about how you engage in that, and that's a discussion we're having right now.
Cool. And our next question is, where can we find these evidence-based practices and the data references you listed?
So when you download the PDF of this, they'll be hyperlinked and it'll take you right to the whole study. You can download the whole thing. And if you want more, you can always touch base with me at my email there. And I can send some things that are more specific to specific circumstances. And I have access. I teach a course in a PsyD program, so I have access to lots and lots of research that other people wouldn't have access to. So I'm always happy to look things up for people because I think paywalls are problematic, that we're keeping people from accessing information about the people they're supposed to be helping. That doesn't make sense. So I will always go and find an article for you.
Awesome. I completely agree with that about
Yeah.
The next question is, what are your thoughts about letting people take calls or chats from home, even post COVID-19? For example, to increase accessibility to work or volunteers, or for overnight shifts.
Yeah. I think it's a really that's a really complicated question. So my entire staff is remote right now, and previously the majority of our workers were on site. So there's a couple of challenges with moving off site. One is that if you're doing an online based system, then you have to have a VPN, a virtual private network that is capable of sustaining that number of people working remotely. So we have about 100 staff, and that's pretty big for us. So that's a big challenge for us, is like the technology, navigating technology issues when everyone is working from home has been a really, really difficult process. And depending on how tech savvy the individual is that's working, communication about what the tech problem even is really challenging. So I think there's some just really logistical concerns about that. Some of our overnight team are reporting that it's way harder to stay awake when there are lulls in our volume overnight. So most of them actually would prefer to work in the center. Our online emotional support team is all remote anyway, so this is not new for them. So anyone who's doing our text or chat services is working from home anyway. From an accessibility standpoint, like absolutely, you should let people who have access issues work from home. That's like a reasonable accommodation. It's actually very, very clear in the law that you are supposed to do that. Um, so I'm going to just sort of separate that as an issue. Like if people have needs around working from home, they should be able to do that, and we should always honor that. Um, there's also some things about doing this work sustainably is really hard. If you're going to take 15 to 30 calls in a shift, which is what we're seeing on our warm line, that's a lot of vulnerability throughout the day. That's a lot of going into dark and scary places. And it's also a lot of encountering systems that are failing people. And I think that's sort of the hardest part of this work is that um, we show up as peers with a collective ethics that is aligned with this idea that people should be able to get what they need, that people are experts in their experience, that they know what they need and they should be able to access it. And we work in systems that that's not how it's set up. And so when you are confronted with that over and over and over again all day, it is really difficult to do this work sustainably. And we start to see people drifting out of this space where they're aligned with their collective ethics into either enmeshment or disconnection. And so what happens is people start to, and when they're doing that, it's because the work is affecting them. So it's a lot easier for us to hold each other in this space where we're accountable to our collective ethics um, when we're seeing each other and can hear the things that are happening in person and things like that. And so there's been this struggle for us as everyone's been working remotely that we're struggling to replicate the things that have happened in our call center where we help people do this work sustainably. Um, I'm not saying that there aren't ways to do that digitally. I'm sure there are. We're just sort of right in the midst of the process of figuring out how to make that work. Um, and and I imagine other people are struggling with that too. So I think there's some challenges there. Um, One of the other things is about equipment. So if you're running your process and your program in shift work, um, oftentimes that means people are coming in and sharing equipment in a call center. So like you only have to have one computer for every 3 staff members. Oh, so we had to go from about that number, 1 to 3, to 1 to 1. And that was a pretty huge undertaking, especially because everyone was panicked. So not just us, every call center was moving to remote work. So we were like running around the state, trying to buy computers places and equipment places that was complicated. So we it took us a while to get to that 1 to 1 staffing. Um, and it was really expensive, and we were fortunate enough to get to some emergency funding. Um, and um, and we were able to do that, but it's a pretty significant undertaking to make sure that someone has a computer, access to really high quality internet that's stable, access to a space that's HIPAA compliant, because we even though there are exceptions to HIPAA compliance, we're still aligning with our work from home policies around making sure that there's privacy for people, having a headset that works, and then making sure that any accessibility things that were honored within the call center are also things that people can have at home. Um, that's a huge undertaking. Um, I do think that we'll probably have more folks working from home in the long run after this, but there's a lot to consider there. I feel like I talked for a really long time on that one. Sorry.
Yeah, that was really helpful. I think a really good overview of kind of all the positives and negatives of having a work from home situation.
Yeah.
Our next question, I'm really looking forward to your answer to this because we've talked about it before and I've always liked your answer to this. So, can you touch on how your warm line would interact with someone that is saying they want to harm themselves or kill themselves and know how they're going to do it, like right then?
Yeah. That's a great question. So our approach is to understand what's going on with that person, and to be really creative and thinking about how we create time and space potentially um, between that and what's going on. So, we have people who call with a gun in their hand, and and that doesn't have to be an emergency right then. So right, so all suicidal thoughts or self harm are not an emergency situation. People who call are typically looking for support. People, that's what people want. We sort of come from a space of understanding the things that are going on, creating some comfort between the caller and the person who is call taking, and building trust. Um, so we really prioritize and value the least restrictive intervention. So it's always our approach, to first see if we can work with people, telephonically, and not have to explore other things. So our approach to suicide, and suicides in progress is to kind of get a feeling for, if there's a medical emergency in that moment, and if there's not, then we're going to use this opportunity to create a space for someone to explore other options if they want to. It's absolutely imperative, and it's evidence-based practice to leave the option of suicide on the table. We never tell people like you can't kill yourself or you can't do this or what any of that. That's never going to be an approach that we take. But our goal is to start to understand, how we got to this place. Like, how did you end up in this moment, where this feels like the only solution? And then, think with people creatively about what other solutions might be. And we really pride ourselves on being able to create plans with people, to help get them through that moment, if that's what they're looking for, that are going to be really different than what you might get on other lines. So we focus on things like, okay, so you told me that it's easier for you, to kind of get through a process if you know that there's going to be a checkpoint, like somebody's going to check in with you. Um, but you're not feeling comfortable about your friends doing a check-in right now. So like, what if you ordered a pizza to be delivered for an hour from now, so you know you're going to have an interaction with someone, and that you feel like you're accountable to that, and that helps sort of keep you looking forward to something and moving forward for the next hour. Or what does it look like if we give you a call back in an hour? Things like that. We also, if someone has started maybe taking pills or something like that, we'll call poison control with them. So poison control can inform them about, what the consequences of that might be. So they're getting like really clear medical advice, or potentially calling a nurse line with them. So there's so many options about, working with people that don't involve like immediately going to this crisis space. I think it's our obligation as people who are providing services to people in crisis, to not meet them in crisis, but to stay as this like calming, presence. And what that means is that we have to be able to take a step back and take a deep breath and be in that moment with the person, um, and to, be able to help, bring them sort of down out of that crisis, so that they can make decisions that they really want to make. Um, but yeah, I think that's really important, is that, you're leaving suicide on the table as an option. And I think, and people's inclination is not to do that. People's inclination is to argue with people about why they're suicidal. Um, but that's not very helpful, because people have probably heard that from at least one other person before.
Thank you. Yeah, I think that's such a great answer. And as we're talking about kind of these approaches to suicide and crisis, I did want to mention NEC we're currently ramping up our efforts to provide virtual trainings in emotional CPR. And that's kind of a similar approach to what you described.
Yeah.
Compassionate response to suicide and other types of crisis that's very non-pathologizing, not resorting immediately to hospitalization or diagnosis, but more just person to person. So I did want to mention, just if anyone's interested in a free online training, please feel free to get in touch with us.
Yeah, and I think it's really important that like we remember that suicide is not the problem. Like suicide is the solution that people have come up with, and that it is like a valid solution. The things that people believe about suicide, as a solution to what's going on, are usually pretty accurate. But it doesn't mean that there aren't other things that they might explore. And I think alternatives to suicide is also a really excellent training.
Totally. Um, So our next question is about peer respites, and I did want to mention, I'll talk more about this later on, but we are having our next webinar in the series is on peer respites, and that's going to be May 20th. But Jess, do you have any thoughts on how that some of these ideas might be able to be put into a crisis respite center setting?
Yeah, I think many of the things are really similar about the way you engage with people, or they ought to be between a warm line and a peer respite. Um, I also think there's a huge benefit to there being warm lines connected with respite care. So within the crisis community, there's a really strong evidence base that if people experience hospitalization, whether it's for suicide or for anything else, a psychiatric hospitalization, their risk for suicide goes way, way up. So we do a follow-up program where people can choose to get follow-up from either a peer or a clinical crisis worker for a duration of time following that experience to help support them because we know people are in this period where they're really struggling. I think there could be similar programming, although I don't think there's similar risk involved in peer respite, but there could be similar programming where someone, read it really needed this more intensive support that involves like a place to stay and, um, connections with peers that are really consistent. Well, after they leave, they're going back to whatever environment they were in before, oftentimes. So that's really challenging. And having Warmline follow up or Warmline accessibility afterwards would be really powerful in that setting as well.
I think that's a great idea. Um, yeah. Our next question is, what is grave disability? And does that mean terminal or potentially resulting in death?
Oh yeah. So grave disability is a clinical term that's about so depending on your state, it might be defined a little bit differently, but it's a mandatory reporting requirement so that you have to report this. That means that a person, because of their substance use or because of their mental health state that they're in, is not able to care for themselves. So it's a tool that's typically used for involuntary commitment.
Do you want to speak at all a little bit more to how that might be handled in a less kind of coercive way or less pathologized?
Yeah, yeah. So on our peer line, we don't do assessments for grave disability at all. Um, so it's a you have to be. I believe you have to be a clinician to do that anyway. So that's a really great workaround. Is if you don't have clinicians answering calls, they can't do that. So it does have to be evaluated face to face, and it's usually by a report. You make a report to someone, and someone else evaluates that. Um, but I think the other kind of work around there can be that, like, ideally in those calls with someone who is really struggling to care for themselves, you're creating support so that they care for themselves, are able to care for themselves or access care. So by creating community or whatever that might be. So I think that's a space where you can really help someone who might be subjected to something coercive because of that assessment.
Absolutely. And then our next question is, are warm lines available in languages other than English and Spanish?
Some of them are. We have a translation service that works with like 100 and something languages. So ours is available by translation. I think there's really big problems with translation services. So it's not ideal, but most of them that I know of are English and Spanish only, although there might be some others as far as like people being able to directly speak with you in that language. Translation services, telephonic translation services are not as expensive as you might think they would be. So I think they're a good option if you're trying to provide services for a broader range of people. But it's always ideal to employ people in the populations that are from the populations you're going to be serving who can speak in the same language and with the same sort of cultural understanding.
Absolutely. Um, and our last question is, find it. Do you provide consultation for starting up a successful peer run warm line, or do you know who does?
I do provide some consultation, and I'm sure there are other people that are doing consulting around that, but I can't think of anyone off the top of my head in the moment. And I have a little bit of limited time, but I would always make a referral if someone contacted me.
Great. And I did want to mention that NEC is available for technical assistance and has resources on our website.
Yep.
So Oryx, I believe, is going to post that to the chat. So I think that's about all the time we have for questions. I just want to thank everybody for coming. Jess, thank you so much for this
Yeah.
great presentation. I learned a lot, and I think everyone here did too. Our next presentation is going to be about peer respites and kind of how that can be an alternative to hospitalization during a time of crisis. It will include some information about research, as well as kind of the practice of it. So please join us for that. That will be May 20th at 2:00 p.m. And as always, you can contact us if you have any questions. We will send out the recording of this presentation. So thank you for being here and see you next time. Bye, everybody.
Thanks.